Welcome to All Home Care Matters, the show where we discuss all things home care, with discussions on important age-related matters and topics. Brought to you by Enriched Life Home Care Services, the #1 rated home care provider in Michigan by Top Rated Local.
Hello, and welcome back to All Home Care Matters. If this is your first time visiting us here at the show, we want to say thank you for taking time out to be with us today. We appreciate how valuable everyone's time is, and that's why we try and make each episode here at All Home Care Matters something that's going to hopefully matter to you. Today, I am honored and privileged to welcome a remarkable person. He's a critical care paramedic and the host of the Pre-Hospital Care podcast, Mr. Eoin Walker. Welcome, Eoin. How are you today?
Thanks. I'm good. Thanks, Lance. Thank you.
Wonderful. I want to start off here because you're obviously coming to us from overseas. You're not here in the U.S. Paramedic and emergency medicine, there's so many similarities, but there are some differences. I introduced you as a critical care paramedic, and when I had the privilege of being on your show recently, you were talking about how you have a lot more autonomy where you're at than we do in the U.S. And just correct me, you're in the U.K. or?
So my practice is in the U.K. I'm based in Germany at the moment, working in the corporate sector, but I'm registered as a paramedic in the U.K. Yeah.
So what is a critical care paramedic? What exactly is that over in the U.K.?
Sure. So it's a paramedic with a certain level of autonomy and education. So the education is master's level education, and the autonomy is kind of rooted in clinical governance. And what I mean by that is there is a certain level of autonomy as far as you go to the scenes as a senior clinician to help in what are very difficult pre-hospital scenes, but there's a governance structure behind that. So there's an immediate reach back. So you've got a higher level of drugs, maybe of decision making, of autonomy, but you've also got an ability to deconstruct the incidents on the back end, pull out the learning, and just make sure that there is some safe practice. I think it's all about safe practice these days. But it certainly is this go-between sort of what we call pre-hospital emergency medicine, so a doctor and a on-the-road paramedic. So it's a high level of autonomy, high level of clinical decision making, and maybe pharmacology as well to help with those really difficult jobs.
Wonderful. Before I get into some of these questions, Eoin, I wanted to ask you, where does your passion come from for emergency medicine? Like, did you have an experience, a story, or something you witnessed? Where does that originate from?
Sure. So I started my life as in the care sector as in rehabilitation hospitals, actually. So not too dissimilar to a care home setting, and so it was for people undergoing convalescence or recovery from stroke, so stroke unit, and also end of life care. So maybe not so much recovery, but more end of life. And those, to be honest, Lance, those had they were profound experiences, and they had profound influence on me. And if I'm being really honest, it was an absolute privilege to be with people at the end of their lives and that last part of the journey. Some people, of which, didn't really have much family, and equally as privileged just to be there, to be able to care for them. And others with plenty of family, but just to see how people kind of approach the end of life, really. And then also with the stroke rehabilitation, how the mindset of patients, how they approached rehabilitation, and just trying to encourage good practice, trying to keep people positive, overcome the micro frustrations of hemiparalysis or hemiparesis, lack of being able to move one side of the body or speech. And that really got me hooked, really, Lance, and that was more hooked on just fundamentally caring for people. And then the adjunctive step to that was more into, like you said, into emergency medicine, into the kind of the pre-hospital care side of things, which was a little bit more fast-paced, a little bit more varied, but nonetheless equally as challenging.
Yeah, no, that's fascinating, Eoin. Let's talk about some of those challenges that paramedics do face when they're working in care homes compared to other environments. I worked in cardiac critical care here in the States. You're directly under, like I was directly under a nurse, the nurse is directly under a doctor, but when you're working in a home, sometimes you're having to think with a lot more autonomy because you don't have a nurse or a doctor to refer to. Of course, you have to still work within your scope and things like that, but you might be reaching out to a family member if it's a non-emergent situation. Let me stress that. If it's, if you're identifying the signs and symptoms of a stroke or a heart attack, you're calling 911, then you worry about getting a hold of the family. But what are some of the challenges you feel that paramedics face when they're working in care homes compared to these other environments?
Yeah, so one of the challenges with care homes, with a paramedic practice and advanced paramedic practice really is around patients have multiple comorbidities, so they're multiple pathologies. They most of them chronic, but some of them can have acute acute presentations of a chronic pathology. And all I mean by that is there could be, we had a conversation last time about some of the manifestations of acute infection, actually. And that can be delirium, it can be what mimics a psychosis, which is extremely challenging. And I think some of the unique challenges there is dealing with someone with multiple comorbidities means they're on multiple medications. They often are quite frail. Therefore, if you are going to approach a patient and you can't use verbal de-escalation and you need to use pharmacological tools or de-escalation or drugs, you have got to be extremely careful because of fragility. They have the partiality to experience the full strength of a drug. So you often have to half dose sedatives and other drugs and be extremely careful about the patient's physiology. You also you're really on the back foot around rapport. They're largely unknown to paramedics. They certainly have rapport with care home staff. So sometimes it's really prudent to direct care through the care home staff because that's sometimes their fundamental carer, and they have the rapport. They have the knowledge of the patient. So it's really important to include them in the care plan, albeit an immediate care plan. And then some of the other challenges I really feel around care homes are that you've got to be extremely careful. And to be honest, Lance, me and you both can speak to this, is around you not being a vector for infection, because people have got reduced immune systems. The people are quite frail and fragile in care homes. And actually, they might have been receiving excellent care in that care home. You don't want to be the one introducing any kind of infection. So being really super mindful of hygiene, maybe mask wearing if that's the correct thing to do in that environment or indeed that ecosystem. But just making sure that you're not making the situation any worse. And then finally, all I would say really is around getting onto the patient level. And what do I mean by that? I mean, actually, if a lot of care homes, the mobility is a major issue. So actually getting down to eye level, sitting down with patients or kneeling down just to really try and deconstruct things. And even if someone is nonverbal, a little bit of kinesthetic touch. So just touching their hands, just reassuring them that they're going to be okay. Again, it's a lot of the non-technical skills which are really important, because actually sometimes the touch of a hand on a hand can just reassure patients that actually, even if they don't understand what's going on, it's that they know that you're there to care for them, and that speaks 1,000 words.
And that's almost as powerful sometimes as a pharmaceutical intervention. Just knowing someone's there, that's listening, that cares and wants to help them. Let's talk about that though. Sometimes communication is key, and paramedics often are the first on scene, or maybe they're second if the care home worker reaches out to them. How can paramedics ensure an effective communication with the care home staff, especially when it is a transition? They're handing over the patient or the resident to you. You need to know as much as possible, because maybe the person's nonverbal, maybe they can't provide a good history. What are some of the effective communication tips, and how can you do that, especially when you're dealing with handovers?
So, Lance, you're based in the US, and within the US, it's famously known for really good, optimal catering and service, the service industry is excellent in the US. One thing that servers in the US do is they do something which I'm surprised more service industry personnel don't do in UK or in Europe, which is closed loop communication. So they might say, right, you want a burger, you want fries, and you want a Coke Zero. So they'll read back to your order. Now, this read receipt, this closed loop communication, to your point, Lance, about complex care plans, complex medication inventories, complex chronic pathology. What I want to do with care home staff when they come up, when they're telling me the handover or the patient history, is just repeat it back to them so that they know I've listened and that actually there is a read receipt for some of that complex information. It sounds so fundamental and simple, yet it's not practiced enough within the care sector. And I would do exactly the same to you if you were care home staff coming to me, and even to the point where I'll reiterate your name, your age, the circumstances, and just so that there's no discrepancy of information, no entropy of information. These transitions of care are so important because this is actually sometimes when vital information can be lost. So that read receipt, that closed loop communication, getting down onto patient's eye level is fundamental as well. There's often a data handshake between care notes, which is absolutely fine, but it's still important to have front of mind access and cognizance of exactly what's happening with the patient. And then what I would say about communication is that verbalize plan A to the care home staff and indeed the patient, and then you can verbalize a plan B and or plan C if plan A doesn't come to pass. Now, this is extremely pertinent and relevant when there might be florid confusion, or indeed if the patient is delusional because of a frequently occurring UTI or infection. Plan A may not happen, so that you might need to look at plan B or plan C, and that might involve pharmacological intervention. It may not, but it's really prudent to have a fallback plan if the first plan doesn't work, and 9 times out of 10 it will, but there are those circumstances. And the only other thing I would say about communication is you have to be absolutely explicit with communication in care homes. The reason I say this is because there's a lot of bed-bound patients that are going to need transferring from bed to bed. It's of fundamental importance that, number one, it's explicit about how many people are going to do that transfer, whether you're going to be involved in that transfer, the actual level of capability of the patient, and what they normally use. Do they use a hoist? Can they self-mobilize? Can they weight bear? And so to be explicit about their mobilization, because if you're not explicit, things can start to fall apart quite easily.
Right. And a lot of things that could be avoided aren't, right? And, just before we move on, Owen, I'm even thinking about you arrive at a home and there's not care staff, but maybe it's a grandchild or one of the elderly people, maybe it's a son or a daughter, and they're a lay person. They don't understand the complexities and maybe all of the things that are going on with mom or dad. How much more important is communication in that scenario?
It really is super important, actually, Lance. And one of the most important things really is, like you said, it's not just the direct care of the patient. It's actually deconstructing complex information for the relatives. And the way I know that I've communicated well to you, if you're a relative of a patient, is if I've used not using acronyms, so accessible language, but B, that you can actually come back at me with exactly what I've said, so that there is some retention there, because you've witnessed this, I've witnessed this. Often when people interact with care providers, be them GPs, be them paramedics, be them nurses, be them in-hospital doctors, there's often a real lack of ability to repeat and retain information. Therefore, we have to deconstruct information. We have to make it accessible to the point where they feel empowered, they feel like they know what's happening, but they also feel like they're in on the plan. They have some autonomy, they have some leverage that they can speak into. And to your point, sometimes actually the patient is absolutely fine with the plan, you almost have to direct your energy towards the concerned other.
Yeah, absolutely. So let's talk about protocols, because protocols play an important part in our healthcare delivery system. What protocols should paramedics follow when they're assessing elderly patients with a more complex medical history?
Yeah, indeed. So I think number one, it's prudent to, and we said this on the last podcast, it's this active listening piece, and you have to actively listen to the handover and reiterate the handover, especially in complex patients. Number two, it's getting a history of why you're there in the first place. Did they try to mobilize to the toilet and fall? And if they did, it's really drilling down into how they fell. Did they fall forwards? Did they fall backwards? Was it from standing? Was it from a walker? How did that happen? So really being specific about the history. And number three, doing a really systematic primary and secondary survey. One of the things we know about elderly patients, and certainly patients which are frequent care homes, is that they can, even small injuries, so small mechanisms of injury can cause large injury patterns. So you can cause a fractured neck of femur just from fall from standing. Osteoporosis is certainly a common facet to a lot of patients in care homes. So it's been prudent to be meticulous in your primary and secondary survey from top to toe. Find out what hurts, what might be new pain versus old pain, and be very, very careful and cautious, but very meticulous, because small injury loads can actually lead to large injuries.
And as you're speaking on, I'm even thinking of decubitus ulcers. If the person has, and for people that don't know, those are bed sores, but they're not just a sore. I mean, they actually have severe skin breakdown. They can start tunneling, and that's from being laid in that same position for too long. So you get significant skin breakdown. I've been at a couple of bedsides where they've had to debride these wounds, and it is very, very unpleasant. Just being aware of that, because, you're transporting them on the gurney. And if the paramedics and the staff aren't aware of this, then they could lay on that gurney for several hours once they get to the emergency room, and it's just causing further damage to that skin breakdown. Something that I'm very passionate about, and I know you are, we talked about this in the last time you and I had spoke, and I was really fascinated with the autonomy that you have in the UK with dealing with advanced directives. How important is it for paramedics to be familiar with the patient's advanced care plan or their DNR, their do not resuscitate order? Sometimes families aren't even aware of what their loved one's wishes are, and it may be that you are aware that they have it, but talk about the importance of that.
Yeah, it's super important actually, Lance, and thanks for bringing it up. So it's important that it's written down and that it's explicit, and that it is documented. Care homes normally have an advanced directive or a DNAR, do not resuscitate order. But it's really important that it's written down. It's really important that it's communicated. And to your point, it's really important that it is shared within even just the care home team, so that there is this front of mind information that can be relayed to paramedics. Advanced paramedic practice is nuanced and is challenging, and there is times when, not too frequently, quite infrequently, but when you have to really, when there is an acute situation that you have to speak to the family quite quickly about, and actually find out whether there either is or is not a do not resuscitate order, but actually what is the utility, validity, and usefulness of actually giving a 97-year-old with brittle bones, with multiple comorbidities, who's bedbound, with multiple chronic pathologies, some of which might be terminal, who has not got a DNAR, who has not got an advanced directive. What is the utility in providing advanced life support to this patient? Is it benefiting them? What quality of life are they going to have on the other end of it? Is there any benefit? And these are conversations you have to have with family. It's really difficult if you have to have them in situ when the situation is going on, if it has not been had prior to, you'd be surprised, or maybe not be surprised, how many times this does happen. And it's extremely difficult, but the plenary approach is the approach to take. And what I mean by that is involve the family, involve the care home staff. I often involve reach back. So I've got the senior medical director on the phone as well, just to make sure that nothing's being missed, and then proceed accordingly.
Well, and I also think, Owen, and you may have, I'm sure, have had this experience also. I think sometimes families, and I don't fault them for this, right? It's their mom, it's their wife, it's their grandma. They love these people, and the whole idea of medicine is to sustain life, right? And we've advanced so much, and I can't even imagine what it will be like 50 years from now with the technology and the breakthroughs. But they also, I think, sometimes need just to be told the truth. And what I mean by that is being very blunt. We can attempt to resuscitate 98-year-old grandpa. There's a possibility bones will break. It could cause severe damage. He may end up on a ventilator, never to come off from it. I think sometimes families think resuscitation means you're going to fix it and it's all going to be better if you do that. They don't know resuscitation has a very small chance of success to begin with, though there is a chance. But what is that chance, if it's successful, that person will ever have any meaningful quality of life? And I don't think the average person who doesn't understand medicine and healthcare realizes it doesn't mean we're fixing it. This is what the outcome may be if we resuscitate. And sometimes I think they need to be told in a very kind, compassionate way what the consequences could be if we resuscitate.
No, listen, I agree with that. And I fundamentally agree with what is the restorative state that you are hoping to achieve? We call it CPC, Cerebral Performance Category 1, 2, 3, 4, 5. And 4 and 5 is very autonomous, very much more, ability to undertake tasks of daily life. But that's not, is to your point, it's not always the case. Certainly from an initial state when the patient isn't in a good physical or psychological state prior to a cardiac arrest. And so you're right. And actually what I've realized, to your point, is actually you have to use very simple terms, not necessarily simple, but direct terms, saying your father, your mother has died. We're pumping blood around their body right now. We're breathing for them, but their heart has stopped. What would you like? What's your explicit will? And I'll tell you from my side what we think is going to happen and the achievable outcome we can look for. But you're right, again, it has to be simple, it has to be straightforward. They're often very difficult conversations to have. I think sometimes what I've realized, Lance, is that you sometimes it has to be, rather than front load them with the responsibility of do we stop and do we finish. I'll tell family, look, I can take that decision. I don't want you to be burdened with this, but I will tell you from my professional opinion, after 15, 18, 20 years, this is the outcome and this is what it will be like. So we've ultrasounded the heart, we've taken all the readings, and this is what we think is the right decision. So it's this, again, it's this facilitated decision making, which is plenary in sense, because I want other people to have a voice in that. I realize sometimes the burden is too great, sometimes at 4 a.m. or 5 a.m. in the morning, when, like you said, those difficult conversations have not been had. Right. So you have to step up and make that decision. You want to involve all the immediate family that you can, and indeed the care home staff. And actually, sometimes the care home staff are the first port of call, because they're the ones who've been with the patient for the past 6, 8, 9, 12 months. Right. So, yeah.
And just to piggyback real quickly, Owen, I think that also is, again, why I stress to families, have a conversation with your loved one to know what it is they wish to have done in this event. So you're really taking that decision away from the family altogether if they know what their loved one's wishes were, right? And so they don't have to have that guilt or have that burden on them to make that call,
Absolutely. I couldn't agree more, actually, Lance.
And talking about, care homes and elderly people, when you add a cognitive degenerative disease into the mix, it just complicates or can complicate things that much further. And it's sometimes very difficult. What are some of the best practices for managing elderly patients with cognitive impairments like a dementia or an Alzheimer's?
Mm. So one I think is one I just mentioned, which is this kinesthetic touch, and that really is all around just reassuring patients that they might not understand them. You're not familiar. They might not understand the plan. They might not understand even why you're there in the first place. But the reassuring touch can be extremely powerful. Then the next thing I would say is some people, certainly with degenerative end stage dementia, or indeed pre-end stage, can still have long-standing memories. So actually it's finding out from care home staff or indeed family what triggers those. Is it just to have some music on to calm them down, that they've still got some neural links to some valuable memories that they can tap into, because the neuroplasticity doesn't always die, and certainly with dementia, even in end stage dementia, there's still some neuroplasticity, some neural links to some profound childhood memories. So it's really finding that out if you can, and it's also deconstructing language, keeping patients warm. And just that simple touch sometimes, especially if they're nonverbal, it's profound chronic dementia. It really is about just that caring touch, tonality and intonation as well. So just the cadence of your communication. Again, they won't be able to differentiate what you're saying, but in a nice, gentle, slow tone, that can make all the difference. That they just feel cared for, and that you're taking them to a place where they will continue to have some care. And often that's the difference between somebody becoming scared, and someone just having that reassurance that you're there for them.
Yeah, absolutely. You know, this next question, Owen, is something I'm always fascinated with. In college, it was one of my favorite courses, and it still is to this day. And it's about ethical dilemmas. You know, healthcare delivery or lack thereof is not always black and white. It sometimes can be a very gray situation. I'll give you an example after I ask you this question and you give me your answer, but how can paramedics navigate some of these ethical dilemmas, such as when to escalate care for patients that are elderly or they have, severe chronic conditions where, it could become an ethical dilemma, like we were talking about with the DNR and the resuscitation or withholding resuscitation. Speak to that for us.
Yeah, it's difficult, isn't it, Lance? It's difficult. I would say, to my earlier point about involving a plenary group, it's super important to do so, because actually not only is it evidence of reason and rational decision making, you're sharing that in the moment so that people can speak into that, just to make sure you're not missing anything. It can also be documented if you are going to withdraw care or indeed withdraw treatment, not necessary care. I would say the line is, ultimately, if the family don't want you to withdraw treatment and they want you to continue, you have, if there is any disparity and discrepancy, I'd say you have to deliver at least basic care until you get to. Now, it doesn't mean you have to go to the ceiling of your care. So maybe not intravenous adrenaline or epinephrine or something else, but you can, if you fundamentally don't think this 98-year-old with multiple comorbidities who's got a terminal illness, who is bedbound and is nonverbal, is going to benefit from that. But if there's discrepancy, I think you have to either tackle that and address that on scene. But if that's not in the care home, if that's not the case and you can't do that, there has to be a continuity of care, I think, until you can achieve that. Now, all that means is that Sure, I've been in some really tricky situations before. London is 6,000 calls a day, 999 calls a day, so you are bumping up against ethical decisions all the time. I had one where I had the husband, and she was in her late 50s actually, but she had terminal pancreatic cancer. She was in an extremely painful place. He wouldn't let go. He would not let go, and she suffered a cardiac arrest, and the paramedics on scene were wanting to do ALS. I said, look, just let's do basic life support right now. I'm going to speak to the husband. He demanded full care, and then I spoke to everyone else around the room, including his relatives, and they said, no, he's in denial. And actually, what's best for her, for his wife, is that you let her go and have a respectful and peaceful death. And sure enough, and we involved the police were there, and the rest, and I escalated that to others around me and to the on-call as well, just to get their perspectives, and there was agreement. But it's super difficult because her primary caregiver and her husband is saying you have to continue, but actually there is no benefit, and not only no benefit, if you're bringing this patient to hospital, there's no adage to the wider care staff, to the patient, to the patient's family, or indeed giving him false hope. And again, that's a super difficult, challenging case. But what it was illustrative of is not going to the ceiling of care, doing basic life support, really working on him, focusing on him, winning the team around him and the family around him, sharing the decision with our team, escalating the decision to the on-call, and then coming to the appropriate, reasonable decision in the end.
That's terribly difficult, and something nobody really should hopefully ever have to be a part of, but unfortunately people are. One example I had that I just think is fascinating, and this was not a personal experience, but a textbook example of a real experience. A mother in her early 60s had gotten early onset dementia, so while she was able, she put down her wishes. She said, in the event that I am not competent any longer, I do not wish to have any life-sustaining measures. So enter, artificial nutrition, so no feeding tube. And this is where the example goes. So her dementia had progressed, and there was about a week and a half, 2 weeks where she stopped eating, and she was in the thralls of the dementia. But then all of a sudden, she had reverted back to sound mind, be very competent. And she said, I want a feeding tube. The doctors didn't know what to do. So they were going to give her a feeding tube. 48 hours later, she's back into dementia and she has a feeding tube. So now, do you withhold the feeding tube? Because now, she's back into a dementia state and it's not going to get better. But when she had those, days of competency, she requested it, but then her advance directive said, I don't want it. It can get very, and that's why I say it's not always black and white. It can be very gray. And so the daughters were given the choice and the ability to make the decision, and they decided to withhold it. But I just feel like, with dementia, sometimes you come back and forth, sometimes you can be here and present and have full competency, but then you can revert back into the thralls of the dementia. And it's very cruel what it does to people, and speaking of daughters, Owen, family oftentimes plays a pivotal role, especially on behalf of their loved one. If their loved one cannot, advocate on their own behalf, what role does family involvement play when paramedics are providing care in that residential facility? And, there's a lot of emotions too. So, you're right in the thick of it. How do paramedics handle that emotionally charged situation?
Yeah. So what we talk about, Lance, is before you ever get to the scene, it's having the right mindset, irrespective of how tired or hungry or whatever's going on for you. And part of that is around de-escalating the scene. And like you said, there's a lot, it's emotive, there's a lot of visceral emotion, especially if there's acute decompensation of the patient and that's a loved one. But we talk about this concept of verbal midazolam, giving people verbal midazolam. And all that means is verbal de-escalation And if you're a family of a staff, it might say, right, finding out your name, Lance. Lance, this is what's happening to your mother, father. This is what we intend to do. We're going to do the best we can do. We're certainly going to look after them. Is there anything that I should be aware from drug allergies or X, Y, Z? And and then work back from that basis, but fundamentally trying to, as long as this situation isn't that acute, try and sit down with the family, because there was a study done, an empirical study a couple of years ago amongst doctors, and the perception, it was the same 5 minutes, but the doctors that sat down with the patients' families versus stood, the perception was that they had unilateral attention, that they spent more time, and that they were far more intentional. So always try and sit down, because that gives you the non-verbal inference that I am there for you. Do that. The verbal de-escalation is around just slow cadence of communication, good intonation, good tonality, just reassuring them that you're there for them. Verbalization of the plan, allowing them to speak into the plan, and then bringing them along for on the journey or into the ambulance, and then to the hospital. But it's and I can, as can you, pick apart people that make good clinicians versus not so good clinicians. Maybe it's the ability to bring the room down a notch, to lower the temperature, to really give that calm reassurance, that slow cadence. And don't get me wrong, there's certain times where that needs to go out the window, and you need to be very direct with your team, with everyone on scene, because the situation mandates it. But 9 times out of 10, you can really work backwards. You can get the family on side. Remember names. Names are key. Sit down with family if you can. Give them the reassurance that they are the most important things, and the patient, your mother, your father, is the most important person and patient in this whole equation right now. And we're there for them, and we'll work on that basis, and then proceed from there. But you've fundamentally won the family over. They're on side, they're on board, and then proceed like that.
Yeah, and I would say too, and it may be the same study that I had read, those doctors that have that more personalized relationship with their patients, and they take the time and let them speak, and they're not rushing them, they're making eye contact, or calling people by name. US, we're a very litigious country. We like to sue everyone. They're also the same doctors that are not getting sued by their patients, because the patients have that trust and confidence. And, I just think it's overall better for the healing process as well.
I would agree with that. I would agree with that. And actually, funnily enough, and this is kind of a little bit bizarre, but there was another study where doctors were compassionate and kind, but slightly incompetent, versus the ones which are harsh, superbly competent, but were getting sued. I think it was actually in Malcolm Gladwell's book, actually, and he said it's a meld of competence and character that wins the day, because you can be extremely competent and still get sued for really, and you can be slightly incompetent, but if you're very nice. But it's this meld of both, and I think it's the having the good bedside manner, and then having the competence to back that up in the background.
Absolutely. Let's talk about, when you arrive on scene, oftentimes it is life or death, right? It's critical. Rarely is it non-critical, or else you're probably not going there as a medic. How can paramedics, though, balance the need for urgent intervention, rapid response, to maintain comfort and dignity for our elderly patients? And I really zero in on the dignity part, because I feel like the uneducated and unaware healthcare professional, or even just society as a whole, people with dementia, I don't feel are afforded the same dignity as if a person with non-dementia of the same age would be given. So how do you balance that?
Yeah, so I guess in a way, when when the situation is emergent, when there's an emergency need there, I think fundamentally you have to make sure that the basics are done well, and that might be airway, breathing, might be application of oxygen or otherwise. But with dementia, there's an acute confused state, and I think sometimes there is, like you said, it's not linear. Actually, sometimes there's a spectrum of dementia, and actually it fluctuates throughout the day. And
Sure.
sometimes, yeah, they can be far more lucid after some fluid or indeed oxygen, or maybe even indeed after some food. So I think it's the balance and the interplay, Lance. And I think this is what you're probing, and I'm glad you're probing it, is being competent and being efficient as a clinician, but also not losing that bedside manner, but more to the point, extending that further when there is a dementia patient that doesn't understand why there's some quick action drills or indeed quick medicine happening around them. It's not losing that personal touch, because because there is quite a lot of frenetic action around somebody. And again, it's having one person speak to the patient in a slow cadence, slow intonation, slow tonality, so that they can at least communicate just with one person, even if that's just eye contact. There can still be a lot of rapid action around that patient, albeit, oxygen, other things, IV access, whatever that is. There needs to be that primal fundamental connection needs to be maintained. And to your earlier point around, I think with acute confusion, there can be acute anxiety.
Absolutely.
So it's trying to dispel that through continuity of care and consistency of rapport, and that fundamentally comes from good eye contact, maybe good touch, just touching the hands, reassuring them, and having that rapport with one person as you go forward.
Absolutely. Let's talk about the skills and training, though, that paramedics go through. What specific training or skills should paramedics develop to improve their response to care home settings?
Yeah.
Tell you
So
my
yeah,
opinion,
go.
I think
Yeah.
is communication and awareness, but
Yeah.
I would love to hear yours.
I think that's absolutely key. I think communication and awareness are absolutely key. I think this closed loop communication is absolutely vital. I think for care home settings, the strict adherence to infection control is absolutely key. I think, like you said, it's understanding the ecosystem fundamentally, Lance. And the ecosystem is you have a number of people, a number of patients living in close quarters that are immunosuppressed, that are dealing with a lot of critical illness, long-standing or otherwise. And actually, there is a fragile ecosystem. So to overly communicate in a beneficial way, to slow down with the information. What I mean there is going to be, like I said, a lot of information, a lot of medications, a lot of maybe history taking. So it's to slow down in that regard, but be very intentional. And the reason I reached out to you, Lance, to first do the podcast with you last time was because this makes up 60 to 70% sometimes of paramedics' daily work. That they're in care homes more so than not, because we have an aging population, because we have a population which is living longer. So this is extremely, to your point, it's extremely important we get this right,
Yeah,
that
absolutely.
we educate paramedics well, and that actually we do focus on communication. We do focus on patient communication, staff communication, compliance to hygiene and risk infection, infection control, but also looking at how geriatric medicine it plays out. Injuries can be masked, quite often are. Small injury loads, small mechanisms can actually lead to quite big injuries. And to your point as well, they might be dealing with a lot of subacute issues such as bed ulcers, but ulceration and/or bed sores that have aggregated over time. So it's a real mixture. But I think the two bases are are communication for sure, and compassion, but also looking at how you approach informatics and information, both to the patient and the care home staff.
Yeah, I agree wholeheartedly, Owen. Just a couple more questions before we wrap up. How can paramedics work collaboratively with care home staff to ensure patient safety and the continuity of care after an emergency intervention?
So this is really interesting. I'm glad you bring this up, Lance, because I think If I'm being really honest, I think that we can do better at patient follow-up, and all that means is that you, as a care home staff member, if I'm receiving a patient from you, I don't think there's any harm in having the ability to feed back to you whilst we're at hospital about the status of the patient's health. Because if that's one of your patients that you care for on a daily basis over the duration of 6 to 9 months, you're really going to actually be really concerned about the well-being of that patient. And if you didn't travel to hospital with that patient, you're equally going to want to know what's happened. So I think follow up from paramedics, or indeed or from emergency medicine colleagues, needs to happen more on a regular basis. Quite frequently, I think the mechanism now is that staff might be able to look at notes retrospectively once they're inputted, but there's no semblance of real-time information coming back to them, and I don't think that dispels any anxiety. So I think we can be better at passage of follow-up information, just to say, yeah, the patient A, patient B are in the emergency department right now. They're doing well. They're stable. X, Y, and Z. They're doing okay. Listen, thank you so much for your help with that. And I think that really, hopefully, adds reassurance and also empowerment and autonomy to the staff, to let them know that actually what they did mattered, and that actually the patient's okay.
Right. Absolutely. Well, Owen, I'm going to wrap up here. First, I want to say thank you. You've become just a great resource for families and for care staff and for paramedics everywhere. Couple final questions. First, we'll have this in the show notes and it's been up on the screen. But for those listening, where would you like people to go to learn more about you and your podcast and the work you're involved with?
Yeah, thanks, Lance. I run a number of podcasts, actually. One is called a pre-hospital care podcast. So it's a podcast for paramedics, doctors, nurses, any EMS staff. So you can find my work there. I also run a podcast called Restore with Eoin Walker, and that is a non-clinical podcast, a sort of wider reaching podcast with just some of life's inspirational characters that have really turned adversity into achievement, and really overcome some adverse moments in their life. Just inspirational stories, actually. So that's Restore with Eoin Walker. And finally, I run the World Extreme Medicine podcast. So I work for a company called World Extreme Medicine as well, and we interview inspirational people that climb Mount Everest, that go to space, that dive the deepest oceans, that go on expedition, that do some amazing feats of illness and injury, and navigate their way through. So you can find my work at World Extreme Medicine as well.
Wonderful. Real quick, who's for Eoin Walker, who's your number one inspirational person?
That's a good question. My number one inspirational person, I would say, it's a good question. I would say, over time, I have a friend and colleague back in the UK who now lives actually in Geneva in Switzerland. He is he's a close friend, but he's taught me a lot about self-development, about being a good clinician, about being a good person. He's brought me on some crazy ultra marathons as well. But he's a friend called Roger Alcock. He has, again, sometimes it's the people in life that just are a real positive influence on you, and that actually draw you to something bigger than yourself. And he's certainly been that character for me, that it's just been consistent over time, and it's just really been almost a mentor, really, I would say.
Is he a physician or another paramedic?
He's a physician, yeah. He currently works for the Red Cross, so the ICRC, but he's also an emergency doctor, but just a real force for good in the world. And
well, we need more people like that. We need more people like that. Absolutely. Well, thank you for that. Finally, an important question: who has the accent, you or me?
Who is the accent? I would say you do, but then you probably say I would, and exactly. I think we'd probably meet somewhere in the middle. Yeah. As long as we can understand each other, that's the main thing. But yeah.
Well, Critical Care Paramedic, and a good friend of mine now, Mr. Eoin Walker, and the host of the Pre-Hospital Care Podcast and your other podcasts as well. Thank you so much for your time today, Eoin. It's been a pleasure.
Thanks, Lance. Thank you so much.
Thank you for joining us today here at All Home Care Matters. All Home Care Matters is here to help families as they navigate these long-term care issues. We invite you to visit us at allhomecarematters.com, where there's a private, secure, fillable form where you can give us feedback, show ideas, or if you have questions. Every form is read and responded to. And remember, you can listen to the show on any of your favorite podcast streaming platforms, or you can watch the show on our official YouTube channel. Just make sure that you hit that subscribe button so that you never miss an episode. I'd also like to say thank you again to Mr. Eoin Walker for joining us today. We look forward to seeing you next time here at All Home Care Matters.
Thank you for joining us today. We look forward to you joining us again on another episode of All Home Care Matters. To learn more about the show and to connect with us, visit us at allhomecarematters.com.